Thank you. So when Rodolfo asked me to talk about this European consensus for management of patients with differentiated thyroid cancer, the first question that arose to me was exactly, what does European consensus mean? It's not easy. But I very quickly found this paper that exactly is the same title, European Consensus for the Management. I don't know if Rodolfo look at this paper and then put the title of this course. But look at the date. It's almost 10 years ago. So I kept searching. And I found this one, which is not very young. It's almost eight years ago. And, well, this is the perspective of nuclear medicine physicians. But in 2009, the Americans, the other side of the sea, they introduced the new guidelines for the management of thyroid cancer. But our colleagues from the States, they appear new guidelines, and there is only one author in this guideline who was also participating in this one. And finally, there is another update of these guidelines that Urania has told to you. And of course, there are all countries introducing new guidelines, for example, the British guidelines. So this is my reaction. Oh my God, what to do? Panagia. I've learned this word finally and introduce it. So keep calm, Javier, and well, look at the details of these papers. And what I saw was that there are two of the panelists of this consensus were also in this one. So what about American and Europe? This is not so different. And interestingly, none of the nuclear medicine were included in this consensus, and none of the nuclear medicine physicians were included in the update. What sounds a little bit strange. And well, in the SNM, they include Susan Clark, which is British, and well, at least there is one. But finally, I got the solution. And the solution was endorsed by the secretary of the ENM, because the thyroid committee, you can see here the thyroid committee personnel, they decide to organize a meeting in Berlin about the European perspective of the revised ATA guidelines of differentiated cancer. So that's great for me. And this is the program of this conference. So we have a lot of information here. So don't panic, Javier. You have got the solution. And I changed the title. European Perspective on the Revised ATA Guidelines 2015. And this is the message I took home at that time. This is Kumali Aktolum from Turkey. And this is the message. Treat sensibly. It's like drink sensibly, well, we can treat sensibly. However, as Camilo told us the other day, there is a big problem, and we have to address the severe increase of incidence of thyroid cancer, especially the papillary cancer. Carcinoma is increasing and hope to be increasing in the next years. So in this lecture, what I'm going to do is to revise the new details of these guidelines, the ATA, of course, the British, because this is also very new, the last year, and also to introduce the comments that arise in this meeting of Berlin. Here are the panelists of these ATA guidelines, as mentioned by Urania and also Sabas. Look at the specialist in this guideline. It's not absolutely balanced. 8 endocrinologists, just 1 oncologist. Remember, this is thyroid cancer. Surgeons, there are 4, 2 general surgeons, 2 ORL, 1 pathologist, 1 epidemiologist, and 1 nuclear physician, because Martinez Lumberger, I never seen him in the INM, but somebody says that he's nuclear medicine physician. Most of the panelists are from USA, but at least 2 from Europe. So I can take this as a consensus of Europe. I don't know. And these are the panelists of the British Thyroid Association guidelines that, interestingly, was published in the Clinical Endocrinology, which is the clinical journal of the Society for Endocrinology and the Endocrine Society of Australia. So this is not exactly British, this is Commonwealth guidelines. Anyway, the panelists are more balanced than the other. There are 5 endocrinologists, 2 radiologists, which is important because they are diagnosing, make the diagnosis of thyroid with the ultrasound, but we are also doing the diagnosis and we are treating the patient, and there was only 1 nuclear medicine here, which fortunately is different than the other guidelines. He's a consultant of nuclear medicine physician in King College in London. They introduced another concept, which is for me very important, which is the multidisciplinary team. So the decision about how to treat a patient should be taken in this committee of different specialties. Let's go first to the first part, is the diagnostic imaging to apply in the preoperative stage of this process. This is what the ATA said. FDG is not recommended as a routine additional imaging at the beginning. What about the advanced thyroid cancer? Well, but they recommend a perioperative voice assessment, which is really important, because some of the patients, if they are not very well surgically treated, they can have some problems with the voice. So this is really important to perform before and after during the follow-up. Recommendation for surgery. This reminds to the past, because in the past, lobectomy was also proposed, but now they introduce, this is absolutely new for these guidelines, the concept of lobectomy and total thyroidectomy for this T1 to T3 with no, with or without extrathyroidal extension as initial surgery. And lobectomy may be sufficient for low and moderate risk papillary thyroid carcinoma. This is part of the message. Treat sensibly, that Furious and Kumali said. Let's go then to the staging and risk stratification, which is a new concept introduced in these guidelines. So the rationale is that the low risk, intermediate risk, and high risk can change after the surgery, but interestingly, after the radioiodine. So they recognize that the low risk with surgery plus can get a remission about 80 to 91%, and the intermediate between 50 to 64, and 31 to 32 in high risk. This means that these patients has changed the risk, so we have to treat after that as redefining this risk of recurrence. Recommendation for radioiodine administration. There are 3 possibilities according to this ATA. Raymond ablation, adjuvant, after surgery to the unknown metastasis or prevention of recurrent metastasis, and the therapy for the very well-known metastasis and disease that could be present. And these are the recommendations. So no recommendation for those who are less under 1 centimeter, T2, T3, and not routinely, and T3 with N1, so lymph node metastasis, we can consider. But, well, you will have only the opportunity to treat all the patients T4 and M1, of course. This is part of the message, treat sensibly. What the British said about this was more or less the same, but they introduced this multidisciplinary team in order to consider the treatment in these uncertain indications. So that's, for me, a good idea to decide in this committee the treatment of the patient in a balanced formation of these specialties. How to administer the radioiodine? Well, they said that both withdrawal, thyroxine withdrawal or recombinant TSH are acceptable for low risk and also for intermediate risk, but consider only the recombinant TSH for those patients who had lymph nodes metastasis. And the doses are very low for these two stages, and between 30 and 150 for those who have lateral lymph nodes in the neck. Interesting. So what the British said is that TSH is recommended for all patients, and they have some doubts about the high-risk patients. They said another things like pre-ablation scat is not indicated, and they pay attention to the renal function of the patients prior administration. According to, or regarding the dose, they said 30 millicuries for this T1, T2. They have some doubts about, which makes sense, to this with the presence of lymph nodes, and interestingly between 100 and 150 for those patients with metastasis. When pulmonary metastases are present, they suggest to repeat the treatment every 6 to 1 year. And there is evidence of ongoing benefit, symptomatic improvement, radiological response, and reduce of serum thyroglobulin. And they say that in bone metastasis rarely achieves response, could be palliative. So these are some of the comments that arose during the meeting of Berlin. So about low risk, why not only routinely? Is this the end of the ablation concept? Well, we will see the results of this trial, which is ongoing, and will prove the concept. About the low to intermediate risk, they say consider, but in the former guidelines they say yes. So should we treat or consider radioiodine in those patients who have been surgically treated with lobectomy? That doesn't make sense. Intermediate risk, consider are generally favored, so no comment about that. And regarding the recommendation about recombinant TSH, if quality of life is a major concerning, why alternatively? Regarding the doses, well, most of the people or most of the lecturers in this meeting say that, well, usually 30 millicuries could be okay. Regarding the adjuvant therapy, should be up to 150 and 100 to 200 for therapy for macroscopic metastasis, and we have to reduce the doses in those patients with older than 70 due to for the possibility of bone marrow toxicity. And here you can see another comments that appear during the discussion. They say, don't just perform ablation. Radioiodine is a great adjuvant oncologic therapy. And for optimal long-term outcome, the first hit should be hard. So this is a message of nuclear medicine physicians of the ENM regarding the dose of 30 millicuries in, of course, intermediate risk. And after negative diagnostic whole body scan, empiric therapy is likely diagnostic, just to clarify. And also they say that dosimetry can potentially improve outcome in highest risk patients. What about the follow-up of the treatment assessment, which is new in these guidelines? They introduced the concept of dynamic risk stratification. So after the surgery, after the ablation, we can stage the patient, the situation can go up or also down the staging. So this is a dynamic process. We have to take decisions about how to follow up these patients depending on the risk after the treatment. So, and they divided the response in excellent with very low recurrence rate, biochemical incomplete, so thyroglobulin still is high, so many spontaneous non-evidence of disease. Structural incomplete. Structural is not exactly CT or ultrasonography, because if you read these 411 sheets of paper, you can see that structural is also the whole body scan using radioiodine and also FDG. So they include as a structural these two functional studies. So in this way, the significant mortality unlikely to occur, and intermediate is most end up with non-evidence disease, a few progress. So it's important to consider this dynamic. According to that, some of the comments were, like the Rosella Elisei said, that in some low intermediate risk patients with 30 millicuries, treated with 30 millicuries, there is no evidence that 30 millicuries can determine side effects. And very low stress for patients' ambulatory administration, because in most of the countries in the European Union, 30 millicuries is the highest dose you can give ambulatory. And 80% reach the status of excellent response from these two risk stages. And they can move from intermediate risk to low risk, so down stage, and their follow-up can be less stressful, reducing the risk of thyroxine suppressive therapy side effects. So is radioablation, ablation with radioiodine is making better not only the life of the doctors, but also the patient's life. What about the refractory radioiodine differentiated thyroid cancer definition? They define this very well, and they suggest stop the treatment. So when there is no uptake, that's very clear. When there was uptake and finally they lose the ability to uptake, is also very clear. Which is not very clear to me is to stop the treatment when some metastases have some uptake, but others not. Maybe it's the time to combine two different strategies. And the same could be said for those who have some uptake, but increase in size. With this comment, or this is one of the comments that arises in Berlin in the meeting regarding these recommendations. The recommendation says, patients with radioiodine refractory metastatic that is asymptomatic, stable or minimally progressive, not likely to develop rapidly progressive, clinically significant complication, and do not have indication for directed therapy, can be monitored on TSH suppressive thyroid hormone therapy with serial radiographic imaging every 3 to 12 months. What about prognosis of markers like thyroglobulin? And what about FDG in these cases? It's not clear in the guidelines. So these are some of the comments. As here, we have time to enjoy it, to meet new people, to do some exercise all around the city, to visit new places. And with this view of the University of Navarra campus, I would like to say see you soon, and thank you very much.
Thank you very much. Thank you indeed. It shows the difficulties of communication. Even though the IAEA and MNS and MMI, we try to have common guidelines till now and we establish also relationship with ETA, I mean in the official level, but till now we have to work hard. About Berlin, I know that the procedure is written and it will be published. I don't know when, but it was a very interesting meeting to see the huge differences between the opinion of the American colleagues and the European colleagues. It's like we are living in two different planets, not in two different countries. And I don't know if the patients are so different. In my opinion, they are not. But somehow we are doing difficult to find the best solution. Any comments, question? Who likes to have the last question? 100 euros for the last question?
They like to do the exam now.
Okay, thank you very much. Indeed. No, he wanted to, is a question?
No.
Without 100 euros, that was a joke, okay? Good. Okay, we finish with the presentation. I mean the scientific presentation because we have a last one. And we continue with the multiple choice question now. Whoever is finished with the MCQ can go out. And we have Rodolfo, how much time? 40?